All right, welcome everyone to our webinar tonight. My name is Sama and I'm the President of GPRA. Our webinar tonight is Optimising Supervision in the context of telehealth. We're very excited to have two special guests for us tonight, Dr. Rebekah Hoffman and Dr. Allison Hempenstall, here to walk us through the context of telehealth, managing supervision and registrar issues, and about optimising your training experience in the context of telehealth. I'd like to begin with an acknowledgement of country. We acknowledge the traditional custodians of the land on which we work and live, the people of the nation, and recognise their continuing connection to land, water and community. And we pay respect to elders past, present and emerging. So as I mentioned, my name is Sama. I'm the President of General Practice Registrars Australia. Today we have Dr. Rebekah Hoffman and Dr. Allison Hempenstall. Beck, if we can start with you, could you please give us an introduction about yourself, where you work, what you do, and a little bit about what got you involved with telehealth?
Absolutely. So I guess I'll start with the last one, because I think what got me involved was essentially the COVID pandemic, and the same as many people, was that I was doing absolutely no telehealth before 6 to 8 weeks ago, and then all of a sudden had a very steep learning curve, I guess, across a few different jobs that I do. And that's where I think I'll go next. Is I'm a new fellow, so I'm a new fellow of the College of General Practice, ACRRM, and so I work clinically in Sydney, and I do that a few days a week. I also work at the University of Wollongong teaching medical students, and that's now all gone online as well. So that does a lot of remote teaching, which I've had to very quickly learn about as well. And then I have some board and educational roles, and doing those remotely is quite new for me as well. So there's quite a lot that I've had to grasp and handle over the last month, which previously I didn't have to do. And part of both my job at Kirrawee and my medical education job at the university is also looking after registrars, so general practice registrars, and then doing that remotely as well, which has been very interesting.
Thank you, Beck, and we really look forward to gleaning your insights tonight. I'd like to pass the proverbial microphone over to Dr. Allison Hempenstall to give us the same lowdown about where she is, what she's doing, and what got her involved with telehealth.
Thanks so much for that, Sama, and thanks for the opportunity to participate in the webinar this evening. I'm an ACRRM Registrar, almost fellowed, and I've been working up on Thursday Island in the Torres Strait for the last 2.5 years. I think I'm in the unique situation, unlike many other GP registrars and GPs in other places across Australia. Telehealth has been a big part of my clinical practice in my remote work. I have regular days where all I do is consultations over the phone, and that's been a regular part of my practice since coming up here to Thursday Island. So COVID-19 was not new in terms of changing my practice, and we're very grateful that we had the technologies in place already. In addition to using telehealth or the phone and video for clinical consultations, I also am a senior lecturer with James Cook University, and so teach medical students who are placed all across the Torres and Cape and on their remote placements. So it's my responsibility to do a weekly tutorial with them, and so I've been using Zoom for a number of years now to provide those tutorials. Many ACRRM committees that I'm involved in have phone meetings, as I'm sure other committees do as well. So technology has been a big part of staying connected for me in a remote community, as I'm sure there are lots of other people. So hopefully I'll be able to share some tips of my experience this evening.
Thanks, Alison. And yeah, we're absolutely thrilled to gain your insights as well. I'd like to kick off the evening with a really simple question. We'll start with Alison and move on to Beck. And this is talking about registrars that are new to telehealth and practices that are new to telehealth. So Alison, could you speak a bit about how a registrar can do telehealth well, particularly if they haven't done that before, when consulting with their patients and working with their supervisors?
I think it's really important, and we're in a very privileged position to have lots of literature around telehealth and how to practice good consultations out there. So I would highly recommend reading our ACGP, Education Online, and ACRRM Education Online, which kind of gives you a cheat sheet on things to consider and things to do in your practice.
Yeah. And Beck, can you speak a bit about how you manage that dynamic, that relationship between you and your registrars, and how you've all upskilled on telehealth together?
Yeah, so I guess at the outset, I'm at a wonderful practice, and so it was all about talking to each other and communication from the beginning. So initially we went from having monthly meetings with everybody to daily meetings and then weekly meetings where we actually spoke about, at the beginning, what our level of comfort was with the situation, and then we decided to go to telehealth quite quickly. And then we did some research into what that would look like for us, organise the equipment, and then how best to support everyone. And for some people that meant supporting them from home. For others it meant supporting them from the workplace to do telehealth, and then worked out the stumbling blocks as they happened. And so essentially the key thing which I've learned is that everything takes significantly more time than what you expect it to. And so whereas if you were previously seeing 4 patients an hour, actually scaling back to only see 3 or 2 initially, until particularly the paperwork, until you've got the paperwork under control. And then important little things like checking phone numbers and email addresses at the beginning before you get the patients off the line, especially if you're going to say, I'll send that through to you. I actually now just keep them on the line until they've received everything via email or fax, and I know that the consult has come to a close, instead of doing it at the end of my shift. So some of the things that I would routinely do on a normal shift, so just do things as I go with the patients, I still try to do with telehealth. So I still try to make sure all my referrals and scripts are done from that patient before I move to the next patient. As far as communicating with my registrar, or with my registrar communicating with me, I guess we had the discussion before we went remotely how we wanted to do that. So same as having that discussion about how you want any aspect of a supervisor registrar relationship to work, you need to discuss what it's going to look like. So for us, we have an app that we use that we can actually message each other if we just need a quick, how do I do this? How do I do that? What do I look up for this? Which works really well. And then we debrief formally once a week to see how we're going.
Okay. Thanks, Beck. So a couple of questions for you. You mentioned that you'd organised, I guess, at a practice level, routine meetings and those sorts of things. Was it always the same person leading those meetings, or would sometimes the registrar get involved quite sort of vigorously in that process?
So the practice manager would always run the meeting and always schedule them, and they were at a designated time. Particularly one of the motivated registrars was delegated out of their interest, though, not out of a requirement, to be involved in initially what the practice looked like when we were doing social distancing, but our practice decided actually to move from social distancing more to remote telehealth, at least initially. Now we're moving back to social distancing. Some of their ideas and things like barriers and tape on the floor and number of chairs in the rooms and things like that are coming back into play. So we've got multiple registrars, and they've all been involved at the capacity which they're comfortable to be involved. None of them have to do any more than what they want to do, but they're all given the option to.
Okay. And the other question I had for you, Beck, is you mentioned that you had an app for some ad hoc message supervision requirements. What do you use?
So we already had one in place called Pink Notes, which is both on phone and on the desktop, and it was already being utilised. And so it was very easy just to continue using that.
Okay. And Alison, what sort of software do you use in terms of communication with a supervisor and maintaining that dialogue?
So through Queensland Health, there is a program whereby we can video conference in different individuals, but that can also, we can provide a link to patients at home, and then they can access video or phone links. In addition, quite a lot of our consultations are just over the phone. So we might be calling up patients who are in their home, and it's much easier for patients here who have limited telecommunications access to just have a phone call instead of Skype or Zoom or WhatsApp.
Yeah. And sort of following on from what Beck has mentioned, I want to direct this next question towards you, Alison. Beck had mentioned that in her experience with telehealth, things seem to take a lot longer. And she sort of reflected that the patient consultation is from start to end. You can't actually put things aside. What's been your experience as a registrar practicing telehealth?
I'm probably in the unique situation where I'm in a very, very small place. And so we only have one pharmacy, and we communicate generally with the pharmacy by email. And same with all our allied health practitioners, we just email them. So I recognise that my situation is perhaps unique, which means that my consultations with patients are actually far quicker. I have a lot of time to be able to listen to them over the phone and ask questions, and I can be writing my notes simultaneously. Instead of when they're in the consult room with me, I prefer that eye contact and that engagement with my patients, and then writing my notes afterwards. So it definitely speeds up the process for me, because I can be emailing the pharmacy, emailing allied health, completing other paperwork online, and writing my notes all at the same time while I'm having a chat with them. So I think depending on your setup will depend on whether or not you're able to, you need a bit more time for your consultations or you need a little bit less. And that's going to be different for everyone, and that's okay.
Okay. And talking about that sort of that setup you have, a question we commonly get from trainees is around what sort of questions or things they could say to consolidate clinical information or do a bit of a handover to their supervisors to ask a clinical question in the context of telehealth. Do you have any lines or tips for trainees in terms of how they can pose questions to supervisors, clinical questions perhaps?
I think it's a great idea. I think it depends on the question. So if there's a really specific question, like I forgot what the dose of XYZ medication is, it might be a really quick phone call, a text message, or using a platform like Beck spoke about, that you can communicate with your supervisor. However, I would always fall back to an ISBAR model that you would kind of use in a handover, because I think it's quick, clear, concise, and gives the key information to your supervisor.
Thank you. And for the trainees that may not be familiar with the acronym, ISBAR stands for Introduction, Situation, Background, Assessment and Recommendation. And it's quite a common form of handover espoused across all health professions. Beck, I wanted to take that question. Thanks, Alison. I wanted to take that question back to Beck around what do you look for in terms of clinical communication for a registrar when they're practicing telehealth in order to support them best?
Yeah, and I'm absolutely what Alison says, and it does change throughout the term as you get used to the registrar that you're working with. So initially, I know the practice that I'm at is much more hands-on and getting to know the registrar and what level of competence and what level of supervision that they want and they're comfortable with. But absolutely, like Alison said, I'm very happy to get a quick message going. Who do I refer to for antenatal diabetes? Is the clinic still open? And I can just flick back a yes or a no. If they want to have a long conversation about something that isn't urgent, I prefer that we either schedule a time to do it or do it in a regular scheduled time that we have it. So for instance, if she has a long, complicated patient that we need to make a management plan for, we might do that in one of our regular teaching sessions, or we might actually schedule a time with the patient together, even if the patient's not there, and sit down and do the plan, and then she speaks to the patient afterwards.
Yep. So it sounds like you sort of have to play it depending on how much time you have in the situation and what the consultation is. One question we seem to be getting from trainees is around a loss of some of that face-to-face time with our supervisors, which I think all trainees do value a lot, around debriefing, counselling about difficult consultations, managing vicarious trauma. Beck, I might start with you, just perhaps to comment on how you manage that in your practice.
So I guess it comes back to speaking with your registrar about what works both for you and for them. So for me and for my registrar, we both have quite a decent commute home. So we'll actually often speak to each other on the commute home over the phone and say, so what happened today? What are you going through? Did you have any difficult cases? And talk about it and debrief with each other on the way home, or on the way to work if we've got something interesting planned for that day. That's what's working for us at the moment, but it just changes. But I absolutely agree with the importance of face-to-face time to debrief, and I actually still try to make sure that I've got it scheduled at least fortnightly, knowing that we've both changed our roster, because it is really important.
Yeah. And Alison, in your experience, how have you managed that softer side of the clinical consultations whilst doing telehealth?
I think just before I get onto that, a point that you were speaking about with Beck before, I find that if I jot down on a piece of paper the things that I want to chat to my supervisor about at the end of the day, so long as they aren't a clinical priority or there's a, immediate issue that needs to be dealt with your patient in front of you. And then at the end of the day, just like Beck has done, or at a designated time having a chat. Now, sometimes it's a phone call. Sometimes I have found with difficult patients, having the trainee supervisor in the consult with me. Now with telehealth, that's a little bit more challenging, but not impossible. A lot of platforms allow, just like we are speaking on now, lots of different cameras to come in. And so I've actually had my supervisor watch me from the computer screen while I've had a consult with a patient in the room. And it's actually probably removed the nerves for me having someone sit in the room with me. And so it's probably a more natural or fluid consultation, but I also get a chance to get feedback from my supervisor at the end. So I think don't underestimate the power of technology in getting supervisor feedback, although they may not be in the room with you.
I'm just going to jump in there and say you can use things that we actually use every day. So there's no reason why you can't have your supervisor on FaceTime while you're doing a telehealth consult, and the patient, let them know that you've got your supervisor there, but your supervisor can be on mute and they can still be there, but doesn't actually have to be interacting with the patient unless you need them to. And that's not intrusive or obstructive to the supervisor in any way, as long as you've given them the heads up that you'll need them for that time during that day.
So you've sort of both made reference to the fact that you do need to be able to be a bit ad hoc and agreeable around using different methods of getting some support during those consultations. What about in terms of the training experience? Alison, I'd like you to sort of talk a bit about how you've managed to optimise your educational experience when doing training, because we're often taught in medical school that you've got to be with patients and sit down with them and hold their hands and examine them to get the best possible training. So how have you managed to either substitute or perhaps surpass that with your telehealth methodologies?
I think there's two parts to that, Sama, that I have found extremely beneficial. Firstly, I'm very lucky to be part of a RTO that provides online tele-style education, tele-education. And so in my first year as a GP registrar, I had weekly online sessions like this, where most people would dial in audio only, but you could put your video camera on if you wanted to, and we would have a medical educator there going through slides, just a bit like in Zoom here, where you see slides that can be shared, and we would go through discussing cases and presenting our own topics and cases as well. So it's something that I'm very much used to. But I think probably moreover than using technology for education, which is very well established prior to COVID, would be the job that I have on the phone with patients for the whole day. And it's probably enabled me to develop a better clinical acumen and judgment for patients, because I don't have them sitting in front of me. You get a lot of non-verbal cues from patients and a lot of other hints on physical examination, and just by having them in the room, that if you don't have them there, it can make your job a little bit more challenging in the short term, but can be extremely rewarding in the long term. I'm very lucky with the phone job that I do. It's providing health services to all the outer islands in the Torres Strait. So they are staffed by a nurse and or health workers. And so the nurse is able to provide a story for me. So I'm getting this kind of secondhand information from the patient, not necessarily talking to the patient, although I do sometimes hop on the TV or speak to the patient directly. I'm getting information from the nurse or health worker who has assessed them before. And I think in that situation, you don't have the patient's voice, you don't have the patient physically there, and yet you still have to make clinical decisions. And so I think having a very key structure that you go back to is really helpful. That is, you start off by taking a history, you go on to your examination, or in the case of my job, it's getting the nurses to do observations and examinations for me, doing your basic set of investigations. So I think it's really easy when you change to a new modality such as telehealth for all that to go out the window. But it's really important to come back to those key principles time and time again.
It sounds like having a structured approach to your consultation that you can replicate is key. Beck, I wanted to direct that last question back to you around, we often with our supervisors would have those ad hoc teaching moments of what do you think this rash is, or in this situation what medication would you give. In what way do you think registrars can best utilise their supervisors to still get those little teaching moments?
I would absolutely still do it the same way. So whether that's your supervisors in the room next to you when you're both doing telehealth, and you can often on their phones that you use, you can actually see whether or not their room is currently on the phone. And that's actually a really nice way of just going, yep, they're free or they're not on the phone. So I can either duck in, or even better, can actually just buzz them on the phone right now and say, what do you think about XYZ? Or you can message them on their phone or on a mobile app if they're comfortable doing that. What we've actually started doing is a regular lunchtime catch up as well, and making sure that everybody has the same lunch time every day. And that gives us quite a nice way to both be social, which is one aspect that you miss when you're doing a full day of telehealth, is not actually having any social interaction with your patients, but also a really good opportunity to say, I saw this patient this morning, I've asked them to come back in this afternoon, can you be free? Or this patient's been on XYZ medication and it hasn't worked, where do I go next? And having informal time slots as well as formal time slots.
And what about, Alison, I'd like to direct the next question to you. We get a lot of inquiries from trainees about how they manage study specifically as opposed to the training experience. And we understand ACRRM's pedigree in terms of utilising telehealth to the best ability to study for a formal exam. Can you tell me a little bit about how you managed exam preparation and telehealth?
I suppose it's just using the technologies that are available to us to best benefit us. Unlike many suburban or metropolitan registrars, I can't really drive down the road for 20 minutes or catch up at a coffee shop. Not that we can really do that anyway at the moment, and catch up face to face, which is what you would usually do, or what trainees might be used to as medical students or junior doctors, meeting together in groups for study purposes. So instead of meeting face to face, we just meet virtually instead. So using platforms such as Zoom to meet and have the same kind of study sessions as we would face to face, just online, or on three-way, four-way phone calls as well, if some people are in locations where the connection isn't so great to have video as well as audio.
And
I'm going to speak to that point as well, because I'm crazy, for lack of other word, to be trying to do a PhD with kids whilst during COVID. And I guess I would say, you've got your exam dates now, you can set a timetable, you can stick to it and have a study group and still be working towards it, but being kind to yourself. You don't have to be perfect during a pandemic. You can absolutely scale back on what your achievements in that timetable is going to be for each week and still be working towards it. So instead of having to cover everything about everything this week, just pick one topic and be kind and do that topic and do it well. And then next week you can move on to the next one.
And can I also say that Zoom fatigue is a real thing?
Yes.
If you are going through telehealth all day and then you're jumping online in the evening and then you're doing a study session on top of it, it is exhausting. And I'm seeing far too much of myself in all these videos than I'm used to. The whole process, I think, don't underestimate how utterly exhausting it is. And I really like Beck's catchphrase of, you don't need to be perfect in a pandemic.
You'd have to trademark that one, I think. Now, the next thing I wanted to talk about was more around functionally using telehealth over the course of the day, and the differences that there are between practicing telehealth either as a registrar or supervisor at home or in practice. Alison, perhaps we'll start with you again. Would you be able to sort of talk a bit about if you've used telehealth at home as opposed to in the practice itself, and how that's been different or worked differently for you?
I think first and foremost, you need to work out, does it work for you at home? You know, there's quite a whole lot of privacy and security barriers that you need to be able to get through in order to be able to access the same remote desktop. If it is that you can access your remote desktop from home, alternatively, having a plan B. What is it going to be? Writing notes in a Word document? Is that secure? Is it password protected? Is that going to then be deleted afterwards for patient confidentiality and safety? So I think making sure that you work with the practice that you're in to have a clear plan as to how you're going to undertake telehealth from home. And that's going to be different from person to person and practice to practice. For me, I use a remote desktop and I have to use 3 different passwords in order to log into it. Because it's a remote desktop, it's a little bit slower than if I was at work. And you got to get used to, not pressing 5 different buttons and the first one hasn't even worked yet. They're just getting used to the fact that having a slower speed is part of your consultation, and maybe that does slow down your ability to see patients, and that's okay, but something you need to take into consideration. I usually open up the patient notes before I call them and have a look through, just like I would if they were about to come into my room. Do I know them? What's their past history? Is there any particular reason why they're coming in? Are there any unactioned results? And then call the patient, video the patient, just like you would usually call them into your consult room. Really important, I think, at the end of any consultation to ask feedback from your patient. So, did this work? Did you hear me okay? Were you okay with this kind of consultation? This is definitely a 2-way therapeutic relationship, and it's really important to get the feedback from your patient. I usually also, going back to the beginning of the consultation, usually like to start out by saying, is this an okay time to call? Do you have any distractions or anything else going on that, might not make this a private and safe space for the patient to talk in? And are there any distractions like children running around, pets jumping up on you, TV in the background that might make it difficult to undertake the consultation? So I think bearing in mind the logistics of having someone sitting at home having a chat with you is really important in consideration of the whole consultation.
Thanks, Alison, for that rundown. And I wanted to sort of draw on the fact that you'd mentioned about, making the home an appropriate and private space for you to have that consultation with patients. But can you speak a bit about perhaps your experience with doing telehealth at home and even about whether you have any registrars that have been doing some telehealth work from home and how your practice has enabled that, or how registrars can help enable that for themselves in a safe way.
Yeah, so yes, both I've done telehealth at home and we have registrars who are doing telehealth at home, and they have the option to either do it from home or to do it from the workplace, and they choose what suits for them. For me personally, it is an absolute disaster because I have got 2 small children, and trying to keep them out of my office and make it a safe and secure place for my patient is really, really hard. Trying to talk to a patient about their discharge with a 2-year-old on my lap is not a very ideal situation, and it was actually a telehealth consult that I had to stop and then phone back this week from my office because I just actually couldn't be a doctor to them in that situation at that time. For my registrars, they're supported to do whichever way they want with a remote desktop as well. The remote desktop was already previously set up because we would use it for checking patients' results or their files over the weekend if we had something coming in that we needed. So we already all had access to that. So that was easy to roll that aspect out. For each of them, they can choose to do either a regular day from home or just as required. So if they're feeling unwell or they're waiting on swabs or they'd actually just prefer to do a telehealth that day, that's fine. We just ask that they give us notice. So obviously we only book telehealth that day. We don't book them for any face-to-face sessions. What we make sure is essential is that we always have someone working from the office. So that means that if anybody has anyone on telehealth that needs a physical review, there's someone there that they can send them to for that review, and that the registrars all know who that is and has a way to get into contact with them and can let them know what their concerns are before they send the patient in. And that's actually been working really well.
Okay. And it sounds like you've set up your practice processes to make that possible. Did you sit down with your registrars and did you sort of go through a written supervision template or plan to make that possible?
Nope, it was entirely ad hoc along the way, which I guess a lot of things have needed to be. So initially, we just worked from the office until some people wanted to try it from home. And then we just worked out the struggles as we needed to. So struggles like how to write a script from home, how to write imaging from home. Did we delay it and send out all of the scripts the next day? That's really easy if you're only doing one session and you're coming into the office the next day. But what if you're doing a week of telehealth from home and things are urgent and can't work till the next day? So yeah, in hindsight, would have been great to have a whole list of scenarios to go through and say, what are we going to do with X, Y, and Z? But we didn't have them, and we worked them out as we went along.
Okay. And speaking of, given that you've had to change your processes around this, what about your in-practice teaching sessions with registrars? Has telehealth changed the way that you do your in-practice teaching?
No, not the formal teaching, because we still do the face-to-face teaching on a regular basis. We do the informal teaching, I guess, isn't the style of teaching I really call teaching. It's more just your quick question and answer. What do I do about X, Y, Z? Which is still teaching, but it is much more rapid, quick fire than what we'd normally do, because normally we'd sit down, have a cup of coffee and chat about it. But we do still do our regular formal teaching.
Yeah. And sorry to hound you a bit with the questions. The other thing I wanted to come to, Alison had made note earlier about the process slowing down, and so had you as well. A common concern that trainees have at the moment is not only around their hours being reduced, but also patient numbers being reduced and declining as well. Do you have any tips and tricks about maintaining patient numbers over the course of telehealth and keeping that workload up and that trainee experience up?
Yeah, absolutely. So I guess everyone has noticed a decline in patient numbers, and for a number of reasons. I've noticed that a lot of patients are concerned about occupying our time, so they don't want to be seen as time wasters. So they'll apologise for taking our time. And I guess explaining to them, no, that's our job. We want to be here. We want to speak to you about it. One thing that I've really made sure that I do, and I would encourage, and I do encourage all of my registrars to do, is to formalise the follow-up. Whereas previously I might have gone, come back in 2 weeks and we'll look at XYZ, or we'll do your mental health plan next month. I'll go, no, let's sit down. Here's our calendar date. I'm going to book you in this Thursday for a long appointment. Or I know I'm going to be in the office next Monday. Come in and we'll do your pap smear then. It's due. And actually formally control my calendar, not leaving it up to the receptionist, because the patient will try and get out of it, and not in the nicest possible way. No one wants to book a pap smear, but saying, this is due, let's schedule it now. And I'll schedule it while I'm on the phone with them before I go. Especially important for kids with colds or flus, or concerned parents, where normally I'd go, I'm going to leave it to you to call me back if you're concerned. I'll actually go, I'm going to call you at 9 a.m. tomorrow morning, so I'll see how you've gone overnight. I'm going to call you again on Friday to see how you've gone, and actually set those times in my schedule. So I've got them there, both as a reminder to me, so I know I need to call them, but also because then I've got that appointment there and I've got it scheduled in.
So it sounds like you need to know when the next patient contact point is going to be. Otherwise, you're going to lose the situation. Alison, can you talk a bit about how you maintained patient numbers, or whether anything like that has changed for you?
I agree with Beck. Patient numbers have significantly declined over the past sort of 1 to 2 months. And I think that's, yes, it is because patients don't want to burden the GPs, but it's also because I think they're quite fearful of coming out of their homes, and they're fearful of coming into GP clinics where there may be other unwell people. Because I would work in a predominantly Torres Strait Islander community, we have the great privilege of having health workers in our community and our health service. And they have been instrumental in maintaining patient contact and ensuring patients come into the clinic. We've been able to get some of our teams in our primary care unit to specifically go out and either do home visits or ring around to those patients that we deem to be vulnerable, and make sure that they have all their scripts up to date, that they don't have any acute clinical needs, and that they can follow up and see a doctor if they want via the phone or in person. So at the moment we're doing, as I'm sure lots of different practices are, a mixed method. So not solely telehealth and not solely face-to-face, but a mix of both, because there are some patients who prefer to come and see you face-to-face, whereas there's those that are quite willing to have phone calls.
Yep. And I guess sort of leading on from what both of you have spoken about, we're speaking sort of from the context of telehealth already having been implemented in your practices. Alison, we'll start with you. Do you have any advice for trainees that are looking to be the champion in their practice in terms of telehealth and get things implemented? We certainly receive inquiries from trainees about their practices sometimes being reticent to starting telehealth or being a bit wary about those processes. So do you have any advice for trainees looking to champion the cause within their practices and change how it runs?
I think it's a very challenging situation, and I'm not sure I'm going to be able to give a silver bullet that's going to cure that particular scenario. But I would say be persistent, find the evidence that supports telehealth, show how it's going to benefit the practice owners, your supervisors and the other GPs, and maybe look at creating a cheat sheet, a how-to guide, because I think a lot of the reticence sometimes is because of the fear of the unknown, the fear of the new and the fear of technology. And so if we're able to, as a keen registrar, nut that down into a very simple, easy to understand pro forma of how their practice, their supervisors, other people in the practice are able to access and utilize telehealth, I almost feel that it's the first or second time that you do something for the first time that it's going to be a bit tricky, and then after that you get the knack of it. So I would say keep persisting to those registrars who don't have those services in their practice.
Okay. Thanks for that. And Beck, do you have any comments about what you, perhaps as a supervisor in that position, would be looking for in a registrar that would be bringing that approach of telehealth to your practice?
And that's exactly what Alison said, exactly that. I want them to come to me with the solutions, not the questions. So coming to me and saying, I want to do telehealth and this is the evidence behind it and this is why and this is how we're going to do it and implement it within this practice in a way that will suit the practice. So not in a small single doctored practice, a way that will suit a multi-corporate, but a way that's going to suit FAST and actually say, and these are the reasons and the evidence behind why we should be doing it.
Yeah, okay. And coming down to sort of a bit more of a philosophical question, Beck, we'll start with you. Where do you think telehealth is going to fit into general practice training moving forward? Do you think it's, to quote the inner journalist in me, do you think it's just because of the pandemic, or do you think it's going to be around for a long time and change training?
I would actually love to see it staying around, not in the capacity that it is at the moment, because I actually really miss the amount of face-to-face that I've lost over the last month. But I absolutely see the value in doing more telehealth, both because we can get the wonderful words of wisdom from people who are in the Torres Strait who we wouldn't have automatically jumped to and thought this would be a great thing to learn from them, but also because it benefits our patients. And I can call them and talk to them about something that I wouldn't want to bother them about bringing them in for a consult for. And I can really easily grab them on the phone and say, hey, this is your normal result that I otherwise might not have brought them in for. As far as teaching goes, I think the number one thing is accessing more people in an easy way who have expertise.
Okay. And Alison, what would you have to add to that? Might be preaching to the choir a bit to sort of ask this question to you, but where do you see telehealth fitting into the GP training landscape moving forward?
I think without a doubt it has to be incorporated into GP training. If it is going to be incorporated into the way primary care physicians practice across Australia and internationally, then it has to be incorporated into the curriculum and into teaching of registrars. And hopefully that will come over time and be implemented as education models for both ACRRM, which do have some already now, as well as RACGP, which have a myriad of resources online for telehealth. So I think that it's been a huge impact to be able to start telehealth now when it may not have been in the past. It's kind of been a huge accelerator to telehealth, and I hope it's here to stay.
Okay. Well, thank you both for that. Now, to move towards the end of our panel discussion, I wanted to pick both of your brains about some top tips that you might be able to give, some takeaway points, if you may, about optimising telehealth in the context of your general practice training and interacting with your supervisor. Alison, do you think there's some key take-home messages for trainees to have about this topic?
I think it's important to know your technology, not only knowing it, but know how to troubleshoot as errors come up. Or if you don't know how to troubleshoot, know who you can call, who can troubleshoot for you. Like I said before, always ask feedback from your patients at the end of the consultation. And I think finally, we're always concerned about not being able to physically examine a patient on telehealth that we do in the practice. I think we can utilize technology to the max to be able to get some basic information. If you turn on your video, you're able to look at a patient and see what their work of breathing is, what their color is. A lot of patients, or elderly patients, especially with hypertension, may have home blood pressure monitoring that you're able to get them to use. Smartwatches can measure your heart rate and even your oxygen saturation. And then most people have a thermometer at home. So these simple devices that a lot of patients have might actually help us in forming an element of an examination. Even though it's not the same as a physical examination in the consult room, it can give us additional important pieces of information.
Okay. And Beck, do you have anything else to add to what Alison has so eloquently explained to us?
So, yeah, I guess my first top tip is going to be to trial and to practice before you call your first patient. I did a number of phone calls to my husband before I called my first patient, because then I could swear at him as much as I want about how to use the remote desktop and how to print the PDF. And we went through and practiced writing a script and practiced writing imaging until I was actually comfortable to do it on the phone with someone who I wasn't ashamed or worried about not knowing how to do something. Not that you should be ashamed or worried about not knowing how to do something, but it was far less embarrassing for me to do that with him than it was with my first patient for telehealth. So just practice. And most sites will have a test patient, and if you don't, your practice manager should be able to set one up for you, which isn't a real patient, is somewhere that you can go and practice taking notes and practice writing scripts, and it isn't actually allocated to a Medicare number or to a real human. My next big one is about setup. And one thing I've really noticed is the musculoskeletal impact of telehealth, and how sitting on your phone with your head against your shoulder for a long period of time is a really uncomfortable posture to be in. So thinking about what your posture is going to be, where your computer's at, where it's set up for a face-to-face may not be the ideal position for it to be in for a day of telehealth consulting, and you should be able to move your room around to suit you. If you need to be using a headset or wireless headphones or actual headphones, then incorporating them into what you do, because they will make a big difference in how you feel at the end of the day. And physically getting up and moving. I still try to get up and stretch in between each one of my patients the same way as I normally would do on a face-to-face patient. And even whether that's dancing up and down my corridor to drop a file at the front desk or to drop a fax at the front desk, whereas I'd normally walk out to get my next patient, but actually moving throughout the day makes the telehealth days much more sustainable than doing back to back to back throughout the day. I guess for supervisors, my key thing is to talk to them. If they don't know that the communication strategy is not working for you, then they don't know. And there's always other options that are going to work. So the easiest one is just a straight message. You've got their mobile numbers, and if you don't, you should have their mobile numbers, is message them. And their phones are invariably at the moment sitting on their desk next to where they are. Find a way that works for both of you to get into contact with them and say, this is how I'm going to be doing it. This is how I'll do it if there's an emergency, and that might be calling reception and getting someone to run up to their room. And this is how I'm going to do it if it's not an emergency and I want you to get back to me when I want you to get back to me at some point. And knowing the difference, but having that plan.
Well, thank you for that. I mean, Alison, you've posted a couple of resources there in the chat. Can you talk a little bit about what you've linked to trainees to have a look at?
Yeah, sorry if all the links are smashed together, but I've posted some resources from both ACRRM and RACGP that are on telehealth and setting up for telehealth, as well as optimising it and some tips and tricks. There's also a PDF document there from the Royal Australian College of Physicians, which talks to telehealth. And the last one is a Don't Forget the Bubbles article, particularly tailored to the paediatric consultation over the phone or video, and that's co-authored by myself and another paediatric trainee.
Excellent. And I think I would say from my perspective as GPRA president, it is important that you can seek external support if you're finding it hard to have those conversations within the practice, and you can contact us directly on inquiries@gpra.org.au, and please join as a member. I'd like to finish up, and I can't see any other questions from any of our attendees. I'd like to finish up by actually thanking Alison and Beck to the best of my ability. I think it's been so useful gleaning both of your insights into how you've managed telehealth in what seems to be a very brave new world for many of us. And it seems to me that having an approach that's both flexible and regimented and has the ability to adapt according to the needs of your patients, of yourself, your supervisor, and maximising your relationship and communication with your supervisor is really the most important thing you can do to get the best quality training experience we can at the moment. And I think going back to Beck's point earlier, you don't have to be perfect in a pandemic. And sometimes good enough is all that we can get in this situation. So make sure to take care of all of yourselves over the course of the next wave, etc., in terms of COVID-19. And I'm sure we'll be back shortly. And this webinar will be recorded for training purposes. Thanks very much, everyone.
Thanks, Sama. Thanks, Alison.